everyone. So we'll be discussing some unique hindfoot lateral pain, and the name is POPS, Painful OS Peroneus Syndrome. So masquerading injuries that are often present as unresolved lateral ankle sprains. There are a list of those, one of which is painful os. As we know the anatomy of both the peronei, both of them course retrofibular. As they go distally, they go on the lateral surface of calcaneus. They are divided superior and inferior by a structure called as peroneal tubercle. Both the tendons have a separate sheath called IPR, inferior peroneal retinaculum, unlike the superior peroneal retinaculum, which is retrofibular and is a common sheath for both. As peroneus longus goes distally, it courses underneath the cuboid into the cuboid tunnel, but just before that, it may have, in approx 10 to 20% of people, something called as OS peroneus, which is a sesamoid bone. Now in patients with a forceful inversion sprain of ankle, or in patients with a varus hindfoot ankle with a cavus foot, there is a constant overload of this peroneus longus as it abuts the lateral calcaneal wall. And this is where the peroneal tendon pathology in the infrafibular course manifests as POPS. It's a spectrum where the pathology could be at the lateral calcaneal wall at the peroneal tubercle, or it could be just before the cuboid tunnel at the level of os peroneus tendon. We could either have a rupture, just tenosynovitis, stenosing tenosynovitis, or we could have os peroneus fracture through the middle of the fragment, which would cause diastasis of the os, as we can see on the right, could be distal to the fragment, where there will be a proximal migration of the os, or could be proximal to the fragment, where there wouldn't be any migration at all. This is a lady, a 29-year-old female, 2-month-old, inversion sprain, persistent lateral hindfoot pain. Not typical ATFL location, just anterior to fibula, but much more distal down. As we can see, a boggy swelling on her lateral hindfoot. Her arches are quite normal. In fact, one would say it is a little flat-footed person, so it is not the typical cavovarus POPS syndrome patient. These are our X-rays at presentation. As we zoom in better, we can see a diastasis of her os peroneus, the proximally migrated piece as well. These are our MRIs. On the left, we see the proximal stump surrounded by edema. On the middle, we see the distal stump surrounded by edema, both of which are non-continuous with each other. And on the right, it's an axial cut in the plane of peroneus longus. We can see the os, we can see the tendon coursing distally and attaching to the base of first metatarsal, the peroneus longus natural anatomy. Now this is what we posted her for. We did a peroneal exploration across the course. As we can see, both the tendons here. The superior one is peroneus brevis, the inferior is peroneus longus. We can see there is a proper degeneration at the distal part of peroneus longus. This is a video here which shows the peroneus longus tendon, peroneus brevis, IPR sheath attached to the peroneal tubercle, the proximal fragment of os, we can see here. And distally, if we trace, there is a distal fragment of the os there. The intervening region is the degenerated, stretched out, granulated ligament or tendon. Attempted healing response, but unsuccessful. And on tugging the tendon further, we can excavate out the distal fragment from beneath the cuboid tunnel. We removed the pieces of os and the degenerated tendon on either sides because they were non-repairable. In this video, we can see that I'm ballotting the first metatarsal. This first metatarsal movement is causing a back and forth movement of the distal stump, further confirming it's only the peroneus longus here. We went ahead with a pulver-taft repair of the peroneus longus, proximal stump, to the peroneus brevis right next to that, and then supplemented it with a side-to-side vicral reinforcement. As you can see, the tendon is well attached to the peroneus brevis. Additionally, to avoid further problems, we also shave away the peroneal tubercle, and we also smoothen the lateral calcaneal wall. My artery is also going in the cuboid tunnel, showing that it's completely cleared of the distal stump. The closure was done, patient had a good recovery and is walking and doing her activities well. A similar case, again, cavovarus foot this time, a typical one. As we can see, the loading pattern, again lateral hindfoot pain. The X-rays show the varus deformity, a subtle small os peroneus, And the oblique view of the foot, the main X-ray, shows the proximally migrated large os peroneus. I don't have the intra photos, but I've drawn a schematic for everyone to see. The lateral surface of calcaneus with the os and the peroneal tubercle. As we can see, the pathology is all around the os. And then we take off that tendon. We can either repair it end to end if the tendon is not sufficiently degenerated, or we can supplement with a tendon graft. But in this case, since we had a cavus deformity, we anyways want the peroneus longus transferred to the brevis for a deformity correction principle. So we didn't bother with the distal work, we just did a proximal peroneus brevis to longus transfer. Again, one more case, we can see proximal migration of both the os. There's a small speck further proximally there. This patient will get a conservative trial. This patient has high arch, cavus, varus, peekaboo heel, everything textbook. We gave a lateral heel wedge, accommodated insole, and good sports shoes to reduce the jerks around the hind foot. And the patient did well with conservative. One more case of conservative, again a bipartite os. This is not a fracture, it's a bipartite sesamoid. And in this case, there is no diastasis, but one should be watchful if there is a diastasis here. Patient did well conservatively also. So take home points, one should recognize this POPS, as we call it, lateral hindfoot pain in a patient after inversion ankle sprain, more often in cavovarus feet. Orthotic treatment is must, can be tried firsthand. If not, peroneal tendon surgeries are the way ahead. Deformity correction in severe varus cases should be done simultaneously if needed. Thank you.